All right, we'll get started. So thanks to, is that working, Steve?
Nope, I just lost it again. For some reason, we lost it.
Yeah, it's all right.
Can we get the OIT team to give us a hand here?
We'll find out in a sec.
All right. It's up in presentation mode. There we go.
Perfect.
Thank you.
All right, so let's get started. Apologize for that. So thanks to Steve for the introduction and for Mihir for putting together this this conference, which has been amazing so far. So as Steve alluded, my unfortunate task is to try and dumb down Steve's words, not mine, endoflip and esoflip for the interventional endoscopist. And my goals here are to kind of describe the technology from the basics, and then to really highlight its utility in areas of interventional endoscopy. And I think one point that I would make is, I think this is one area where the development of a team and collegial relationships with colleagues who have different set of expertise is really critical. And I'm lucky here to really have great working relationships with my colleagues that enable us to really hopefully provide the best care, both to when things are straightforward, but as you'll see, to when they get a little more complex. So the endoflip or flip is the endoluminal functional lumen imaging probe, in addition to resulting in one of the great CGH covers. It's a novel technology that measures luminal cross-sectional area and simultaneously pressure in the esophagus. And with these measurements, it serves as an adjunct to existing esophageal investigative tests, dominantly high-resolution esophageal manometry. And with software that generates time plots, you can use the mechanical properties that you obtain from endoflip to examine contractile patterns of the esophagus, as well as those pressure and cross-sectional area measurements. So from a technical standpoint, the endoflip is a distensible balloon that encases a catheter that contains multiple pairs, usually 16, of impedance electrodes. And then the balloon is distended with a fluid of known conductivity and a known volume. And this relationship allows you to calculate the distance and the diameter of the balloon at different levels in the balloon catheter. You use a mechanical pump in the flip module that controls the distension speed and volume, and then simple touchscreen buttons allow user input into the process of balloon distension. There we go. And with this distension process, you can assess esophageal biophysical and motor responses to esophageal distension. Because of that known conductivity of the volume in the balloon, you can get simultaneous cross-sectional area and pressure within the distended balloon, and that enables the measurement of organ distensibility. So essentially the cross-sectional area divided by the pressure. And this distensibility provides us with a dominant variable in endoflip, which is that distensibility index you've heard mentioned a couple of times. And this is a metric that initially was used in diagnosing impaired lower esophageal sphincter relaxation or esophagogastric junction outflow obstruction, and now it's been used in a number of different anatomic areas of the GI tract, including the pharyngeoesophageal junction, the pylorus, the anorectal area, as well as others. And then because the esophageal luminal distension induces peristalsis, you can plot the changes in luminal diameter in the esophageal body over time. And essentially, you can create changes that can be plotted in a topographic fashion, very similar to high-resolution manometry. And you're seeing that on the right side of the screen, where you have the distension that's seen in the balloon placed in the esophagus over time, and it looks very similar to what we see in high resolution manometry, keeping in mind that high resolution manometry measures primary peristalsis, and what we're seeing here is distension induced secondary peristalsis. When high resolution manometry was developed, it was really the development of the Chicago classification and the subsequent variables, such as the integrated relaxation pressure, that enabled facile interpretation of manometry. While we aren't there yet with FLIP, the dominant metrics that we use are pretty well established, especially the distensibility index, and especially as it relates to the esophagogastric junction. So again, with the distensibility index, we're measuring the cross-sectional area at different locations in the esophagus, and then dividing that by the intraballoon pressure to get that distensibility index variable. Across the esophagogastric junction, normative values suggest that the distensibility index is 3.1 to 9 millimeters of mercury, millimeters squared over millimeters of mercury, whereas an impaired esophagogastric junction opening is 0 to 2 millimeters squared over millimeters mercury, with borderline being that 2 to 3 range. And this has been well established, examining achalasia as the archetypal disease with decreased EGJ opening. And what that looks like on our EndoFlip screen, this is using the EndoFlip 1.0, is on the left. You have a normal distensibility of 4.9, and you see that with balloon distension, you get an adequate balloon pressure, and then the lower esophageal sphincter opens to 14 to 17 millimeters. Whereas on the right, in an achalasic patient, balloon distension does not lead to the same cross-sectional area at the EGJ, and therefore you have a reduced distensibility index of 1.1. Consistent with impaired LES relaxation or EGJ opening. As we mentioned, you also can look at contractile patterns when you plot the changes in distensibility over time. And this was described dominantly, but again, by the Chicago group and Dusty Carlson, where they looked at normal contractile patterns, which are on the left, that again look very similar to normal peristalsis on high resolution manometry. These are repetitive antegrade contractions on the left. Those are considered normal. In the middle, you have really absent contractility. That's considered an abnormal finding, and if associated with reduced distensibility index, can be associated with type 1 achalasia. And then on the right, you have abnormal retrograde contractions or repetitive retrograde contractions, or RRCs, and those can be associated with type 2 or type 3 achalasia, as well as esophageal spasm. So those are the metrics that we're examining when we perform EndoFlip, especially as it relates to the EG junction. And the HEA presented best practice advice on the utilization of FLIP, and really highlighting that as clinicians, we should not be making a diagnosis or treatment decision based on FLIP assessment alone. And I think this really highlights or just emphasizes that FLIP is an imperfect tool to date. There are a number of reasons why FLIP has certain limitations, not only the cost of implementation, but the software does not lend itself at this time to real-time analysis. And so while we get a real-time distensibility index, you can't then really mitigate or further analyze the data in real time. And so while we're waiting for somewhat improved software metrics and analysis availability, we use FLIP dominantly as a adjunct in our other diagnostic modalities. And this really is highlighted in achalasia, where we see FLIP as a complementary tool to high-resolution manometry or barium esophagram in identifying outflow obstructive disorders. In multiple reported series and cases, FLIP can be used as an alternative to high-resolution manometry, though not the sole alternative. And FLIP can demonstrate abnormal EGJ distensibility in patients who have typical achalasia symptoms or findings on endoscopy and barium, but without classic high-resolution manometry features of achalasia, specifically in those who might have normal integrated relaxation pressures. And this was demonstrated in a retrospective study of 34 patients who had idiopathic esophagogastric junction outflow obstruction that did not meet criteria for achalasia. And in those with a normal distensibility index who were treated conservatively, they had symptomatic improvement, while those with a low distensibility index treated with achalasia type therapies improved via Eckert score. And this kind of shows what we see in FLIP in achalasia, where in the top panel you see a healthy control with normal EGJ opening in the setting of increased balloon volume distension with a normal distensibility index. And then on the bottom 3 images, you see a lack of opening of that EGJ, a low distensibility despite increased balloon distension volumes. And then how we use this at our center with Mahir, Hazem, Steve, and others is in settings where achalasia may not be a certain diagnosis. On the left here was a high resolution esophageal manometry where certainly panesophageal pressurization was noted, but the IRP was noted to be within normal limits. We'll use FLIP frequently as an adjunctive diagnostic to try and confirm impaired EGJ opening. And in this case, EGJ distensibility was less than 1, and the patient was then was referred for a subsequent POEM. And then in the setting of achalasia for interventional endoscopists, there's been work looking at the use of FLIP after lower esophageal sphincter-directed therapies for achalasia. And FLIP can be used to assess the degree of post-therapy EGJ disruption after really any LES disruptive therapy, but POEM specifically. And we found that the final EGJ distensibility index and the cross-sectional area during POEM, myotomy, and pneumatic dilation correlate well with clinical response in the studies that have used intra-procedure FLIP. And then furthermore, specific to POEM, during POEM, it's been shown that the creation of the tunnel and the myotomy results in subsequent distensibility index increments at the EGJ. And that change in the distensibility index was actually highest compared with those in surgical myotomies with the partial fundoplication. And then furthermore, the increase in distensibility index at the EGJ correlates with symptom improvement, with optimal symptom improvement obtained with a post-procedural distensibility index of 4.5 to 8.5, suggesting the ability for intraoperative FLIP to tailor the length and degree of myotomy. And this is an image kind of describing that, where on the left, you have the impaired EGJ opening on FLIP prior to POEM. And then on the right, the post-POEM EGJ picture with a subsequent improvement in EGJ opening and distensibility index. I'll briefly talk about endo-FLIP and anti-reflux procedures. I'm curious to see to hear what Ken thinks about this. But endo-FLIP has been used to try and tailor and examine anti-reflux procedures. I will, just as a way of backdrop, the literature as far as endo-FLIP and reflux disease is kind of all over the place, where certainly some studies have revealed very high distensibility indices in reflux patients, but normative values have really been all over the place. But FLIP has been used in patients having undergone fundoplication who are noted to have lower distensibility indices on FLIP rather than controls who have not undergone fundoplication. And then that decreased distensibility index has also been reported after transoral incisionless fundoplication. Endo-FLIP has been used to tailor anti-reflux surgery, fundoplication specifically, with examination of the EGJ distensibility index before fundoplication, after the hernia repair, and then after the completion of the fundoplication. And then final intraoperative distensibility indices less than 2 are associated with both dysphagia and gas bloat syndrome, suggesting the ability of endo-FLIP to really tailor anti-reflux procedures to improve symptoms and outcomes, but also to minimize complications. And a distensibility index of 2 to 3.5 suggests an optimal post-fundoplication outcome. This is an image out of the Chicago group where the first image on the left is the pre-fundoplication distensibility index (EGJ) image, and then the second is after the crural repair, and the third after the fundoplication. Mihir kind of touched on this already, but FLIP's also been examined in gastroparesis, where pyloric distensibility may correlate with gastric emptying. And furthermore, early satiety and postprandial fullness may be inversely correlated with pyloric sphincter diameter and cross-sectional area, suggesting a potential role of FLIP in the evaluation of gastroparesis. So using a pyloric distensibility index of 10 millimeters squared over millimeters mercury, nearly 1/3 of patients with idiopathic or diabetic gastroparesis had decreased pyloric distensibility. And then looking at the result of treatments, Mihir mentioned this, but GPOM does increase pyloric distensibility, and a pyloric distensibility of less than 8 to 10 can predict favorable outcomes after pyloric-directed therapies, including GPOM. So before we get to hopefully some discussion, I wanted to bring up the second area of conversation, which is the use of EsoFlip. And so EsoFlip uses the same hardware, but a different catheter, same software and hardware, but a different catheter. So an EsoFlip dilation catheter is based on the same technology. And it allows dynamic monitoring of diameter and cross-sectional area while performing hydraulic dilation, with the EsoFlip catheters going up to dilation diameters of up to 30 millimeters, so akin to your smallest pneumatic dilation for achalasia balloon. And this enables comprehensive illustration of the esophagogastric junction or the pylorus during intervention without the need for fluoroscopy. And so in achalasia, EsoFlip has been shown to reduce Eckhart score, and also decreases the median height of barium column. This is what EsoFlip looks like at the EGJ, where you're dilating the esophagogastric junction up to 30 millimeters, similar to pneumatic dilation, but again without that need for fluoroscopy. So these are the endoflip images, where on the left you see the gastroesophageal junction as the waist on the initiation of balloon distension, and then at maximal distension on the right, you see the EsoFlip obliterating the waist during the dilation, and a EGJ diameter of about 28 millimeters. EsoFlip's also been used in gastroparesis. 75 patients with gastroparesis in the largest study underwent EsoFlip dilation to a target diameter of about 25 millimeters. And pyloric dilation with EsoFlip decreased gastric emptying times and improved distensibility, as well as symptom and quality of life scores. We touched about it briefly in the previous session about some of the challenges of getting the EsoFlip and the endoflip balloons to traverse the pylorus. This is what that looks like. And then during dilation, looking through the EsoFlip balloon and seeing the blanching of the mucosa during pyloric dilation, and then the post-dilation image on the bottom right there. So then I wanted to really try and stimulate the discussion part of this talk is really, where do endoflip and EsoFlip and their use lie for the interventional endoscopist? Here we've been using them, especially EsoFlip, when as a potential achalasia therapy if POEM is not feasible. It might be a little more feasible to perform EsoFlip in a dilated esophagus, or in one with significant fibrosis, or when it's technically challenging to perform POEM. And it might be a secondary achalasia treatment if distensibility index still isn't reduced, or if it's borderline post LES disruptive therapies. And then again, it might be a potential pylorus-directed therapy if GPOEM isn't feasible. So with that, I've kind of started with some potential discussion topics. I'm curious about the audience's use of endoflip as well as EsoFlip, and whether some of our experts or anyone in the audience is really using intraprocedural endoflip during POEM, during GPOEM, or during TIF. And with that, I thank Mihir for organizing, and I'd love to hear some discussion on the subject.
Great, thanks, Paul. Mihir, did you have a comment?
No, I was just going to invite some of our panelists who are still on the call if they want to join in, especially about whether they're using EndoFlip and when they're using it and when they're using EsoFlip.
Ken or Stavros, could you comment?
Yeah, I use EndoFlip. I haven't used EsoFlip. We don't use much dilation really at Winthrop.
We understand.
Yeah.
Shocking.
But no, but funny story. I was with Jason Samarasena at UCI like 3-4 years ago. I went to see how Ken does this plication with overstitch, and he did an EsoFlip, and it was a perforation. That is my only actual live EsoFlip procedure, and it was not so unfortunate like with Jason. But yeah, EndoFlip I use on every poem. I mean, we in our publication in GIE that is coming in print in the November issue, we have data on 500 EndoFlips pre and post poem, and on 300 plus patients, we're able to do it again on a mean of 7 months later. The interesting, so we try to predict GERD, try to predict efficacy, as others did. We found it very confusing. I think we don't have enough failures due to inadequate myotomy for EndoFlip to be proven useful. There's a great increase in distensibility. We also found that the last 3 years we do an anti-reflux kind of poem where we don't cut the sling fibers, and now instead of our distensibility at 50 after poem being in the 7 to 8 range, it's now in the 4 range. So you see differences. We also found that the EGJ remodels. So the distensibility goes up to like 8, 9, 10 immediately after poem and then drops by 20 or 25% at 7 months. That jived with pH data we have that show improvement in reflux long term. So it's a very useful tool. We just cannot, in an expert series, we cannot find the proof that it predicts failure. If you do it on beginners, it's gonna be great. Because, in an inadequate myotomy, you should immediately see a distensibility of 1 or 2 and know that. So I think it's useful. I just can't do it. Same thing with GERD. Difficult to prove because also 20% of our patients are sigmoid with previous Heller. They start already with a high distensibility. So, but I think it's useful. That's why I'm still doing it after 550 procedures. I mean, I would have given up if I didn't, think it provides some extra data. And as you saw, it helped with the reflux. We saw the improvement in reflux at 3 years or more pH study compared to the initial pH study, and a very similar trajectory on the EndoFlip distensibility. So, yeah, I think it's useful.
I'd be curious, Ken, I mean, do you think that this has any role in predicting which POEM patients would benefit from an immediate anti-reflux endoscopic procedure, or do you think it's just too confusing right now to understand that?
Yeah, I don't think EndoFlip will be able to tell us that. Yeah, I agree with everything several said. Yeah, we use it all the time pre and post intraprocedurally, and we try to target the DI as much as one can target to be in the high 3s, in the 4s. But sometimes you do the myotomy and this disability is 8, and I don't know how we can actually control it. And I don't know that that necessarily predicts GERD. I think there's more to GERD than just the distensibility, although that is one factor. But I think cutting those sling fibers is what we've been doing inadvertently. And the strategy of avoiding the sling fibers and rotating into that lesser curve to finish the gastric side of the myotomy is very important as a strategy. And then we have, just the garden variety workup of GERD patients. And we struggle with, is this someone who just needs an endoscopic fundoplication with TIF, or do they need a laparoscopic repair? The Hill grade is woefully inadequate. And so we've looked at EndoFlip to see if that can help predict an open hiatus at the time of surgery, and it may. But the problem is that the EndoFlip distensibility reflects both the esophageal and the crural pressures combined. So if you have a Schottky's ring, your DI is low, and you may have a huge open hiatus, but you're not going to sense that because the Schottky's stricture is preempting that. So unfortunately, those two things can be disassociated too.
Any use in detecting or guiding therapies for gas bloat and other symptomatic issues after fundoplication or TIF?
Yeah, so no, I think patients who have gas bloat before any procedure are likely to have gas bloat afterwards, for sure. But I think the aggressiveness of the dissection laparoscopically and the aggressiveness of the TIF, probably the laparoscopic is more of a factor, I think, than the TIF itself, but probably combined for gas bloat. But since we're now routinely following patients up around 3 months with an endoscopy and pH after the combined TIF laparoscopic hernia repair, if at 3 months they're still having some gas bloat, I will empirically do a Botox to the pylorus, and that anecdotally really does help shorten that gas bloat.
Interesting.
Yeah, because by the time they're far enough out that the gas bloat would naturally have dissipated, that's when the Botox would be wearing off. So it's kind of you just making that duration shorter.
I see. All right. Very good. Any other comments from the panelists? All right. Well, I think what we'll do is move on a few minutes early. Paul, thanks so much for a nice basic education on ESO flip and flip. All right. Have a good afternoon.